Good morning, everyone. My name is Dr. Wei Tan. I'm one of the electrophysiologists at the University of Cincinnati. So first of all, I want to thank you guys for being here, spending time out of your Saturday and be here with us. So today we're talking about atrial fibrillation. Specifically, what I want to talk about is the kind of atrial fibrillation that actually comes and goes, and more importantly, how we can take something that feels so unpredictable and trying to get into something that a little bit more understandable and maybe manageable. So in order to do that, we are going to, in the next 20 minutes, we're going to go ahead and talk about some of the questions that I get asked a lot. Next, what does it feel like? How do I know if I have atrial fibrillation? How do I track it if I do have atrial fibrillation? Why it happens? How can I treat it? And importantly, when should I get help? So I was in a similar situation about 4 weeks ago. So just like a lot of these drivers on the road, atrial fibrillation can be very unfeeling. And by the way, I was not the one who was kind of turn right. So when a patient first experiences atrial fibrillation, usually this is the feeling. It's very unpredictable. It can start suddenly, stop suddenly. Your heart rhythm becomes irregular. This is not something you have ever felt before. And that uncertainty, a lot of times, is the hardest part of this condition. AFib is not just a heart rhythm problem. AFib really is a uncertainty issue. So in order to understand AFib a little bit better, we're going to delve into what AFib is. I too like to use analogy in this. So if your heart is like a car engine, AFib is like a car cylinder is divided. It can be slow, it can be fast, which most of the time it is. It can be at a normal speed, but the problem is the timing is just consistent. So this is one of the questions I get asked the most in clinic. So what am I supposed to feel like? So for most patients, the most common symptom that I hear is exercise intolerance. So what that means, right? So say if you're able to use the walk up 4 flights of stairs without issues, or you're able to take pickleball for an hour without breaking, in atrial fibrillation, a lot of times after 1 flight of stairs, you're often pumping, or you need to rest after playing sports for about 10 minutes. So the next big one is shortness of breath. So this can go as mild as I just can't seem to take a deep breath in, all the way to feel like the air is getting a little bit more thin, to feel like you're drowning. Palpitation is a big one. Like the previous one, there's mild cases and there's more severe cases. The mild cases, the most common one that I hear is, I would only notice it when I go to sleep at night, especially when I lay flat. I feel like there's little butterflies fluttering in my chest. It can go as severe as I feel like my heart is pounding. It's so intense that it shakes my whole body. Some of the more scarier ones are the ones that make me dizzy. Those are the ones that it comes on, I feel dizzy, the room is spinning, I gotta lay down right away. Otherwise, I feel like I'm gonna pass out. And some patients just tells me when I'm in AFib, I just can't think straight. So AFib usually doesn't stay the same all the time. And when it starts, typically it starts as occasional episodes. You have an episode there, here, you have an episode there. And it can become gradually more frequent over time, or just last a little bit longer each time. So this picture is a representation of my patient's AFib symptom diary. So the gray box are the ones that he does not have AFib that day. The one that is in red, he has AFib, at least that you can tell that day. So at first, as you can see, the first month, he barely has any AFib episode. As time goes on, these episodes tend to become a little bit more frequent. Maybe they last a little bit longer. Sometimes they just become a little bit more noticeable, or they're just a little bit harder to ignore. And you may find some similarity to your experience and start to form patterns. And that can really create frustration because it can feel like things are really just changing without any warning. But remember this, you're not alone. At least 5 million Americans do have AFib. So that comes to the big decision, right? What are we going to do about it? So this is where we start making decisions together to how best we manage the AFib population. So you hear about this a little bit already. So two main ways where we approach AFib population are rate and rhythm control. So first you have the rate control. This is just to slow down the heart rate, make sure your heart rate is in a safe place. To use that to the car analogy, right? So rate control's velocity is just pumping the brake. Your firing timing is still off, right? But you just slow it down. Versus rhythm control, it's more actually fixing the rhythm itself, trying to keep yourself in on. So this is actually going to the engine most of the time and try to fix the engine, make sure they're not misfiring. So many years ago, medication used to be the main, if not only option for treating atrial fibrillation. Ablation has been here for many years, but in the past 5 to 10 years, technology really has advanced to a point where it's becoming the cornerstone of atrial fibrillation treatment. Whereas medications serve more as an adjunct to an ablation. And we'll talk more about that. And in terms of medication, you can also think of them as rate control medications or mainly rhythm control medications. So for rate control medications, I know many of you are familiar with like metoprolol, cortisone. These medications are generally a lot better well tolerated. They have fewer side effects and milder side effects. They require a little bit less intense or regular monitoring. They are best at just slowing down the heart rate, not so good at keeping on with it. On the other hand, we have our rhythm control medication. So these medications are stronger medication, but the trade-off is that they tend to have a little bit more side effects. So medication like amiodarone can cause stomach upset. People can get dizzy from them. Some of these medications tend to interact with other medications. So with that said, most of these medications require a little bit closer monitoring, either be with EKG or with blood tests, or just closer regular follow-up. With the trade-off, like I said, these medications are a little bit better at keeping normal rhythm. So when we say medication is working, we don't really always mean AFib is disappearing completely. So for medication, what we're really looking for is that we have fewer episodes. So what that means is that perhaps a less frequent episode or episode that doesn't last as long. More importantly, we want you to feel better. With fewer palpitations, you will get back to doing what you like to do, a little bit less fatigue and shortness of breath. And one thing that's important is that we want to get into a stable heart rate. So I think we need to set expectation, for medication. For medication, it doesn't cure AFib. It's something that it manages over time. About 1.5 patients get decent rhythm or rate control with medication alone in 1 year. So the goal for medication is not perfection. The goal is to control it. And that's okay because we have other tools to control atrial fibrillation. So that leads to the beginning of our ablation talk. So we will have an ablation talk more detail in later talks, but I'll touch lightly. So AFib often start from small area from the heart. These small abnormal area send out signals, abnormal electrical signals. And these electrical signals actually are the ones that trigger atrial fibrillation. So the point of an ablation is to go in, we find where the signal is coming from, and we block it so that it can't trigger. So in here, I will be mostly focusing on non-surgical ablation and surgical ablation, obviously, talk about more as well. So this is not open heart surgery. Catheter-based ablation is a minimally invasive procedure. We go through a vein in the blade, and using that vein as a channel, we move our catheter into the heart. Once we have catheter inside the heart, we sense where this abnormal electrical signal is coming from, and we treat the heart. So there are no large incision with these ablations. Most patients after an AFib ablation, we go home the same day. So one thing that I want you to remember is that AFib is not completely normal. They are triggers. And many of these triggers are things you can actually control. So if you can find your trigger, you can find your pattern and take control of the AFib. So these are some of the short-term triggers. One of the big ones is alcohol. Study has shown that even small amount of alcohol can trigger AFib. Poor sleep is also a big one. Say if you have sleep apnea, you're waking up at night all the time, that stresses your heart, or someone else sleep apnea is waking you up. That can cause stress to your heart too. Illnesses is a big one, especially infection. When we get infection, the whole body is fighting against it. It promotes a lot of inflammation inside the heart, and that inflammation can certainly trigger atrial fibrillation. Or you just don't really feel well. You're sitting in bed, you don't want to drink, you don't want to eat, you become dehydrated, and that certainly can trigger atrial fibrillation. And stress is what everyone knows about. Emotional stress, physical stress, and certainly trigger atrial fibrillation. So here are some of the long-term triggers. So these long-term risk factors and triggers are the one that's a little bit harder to modify, but changing these long-term factors often has the biggest impact on the atrial fibrillation. So one of the big ones is high blood pressure. Right? So your heart is pumping against a lot of pressure, and that creates strain into your heart that can trigger atrial fibrillation. Lack of exercise. Not only when you don't do exercise, not only your leg and arm muscle become deconditioned, your heart muscle also become deconditioned, and that can evolve into atrial fibrillation. When you have excess weight, your heart is working harder to supply this blood into more area than it needs to. It creates extra stress into your heart. And if you have weak heart function, certainly that can trigger atrial fibrillation. And one of the really big ones is sleep apnea. If you have sleep apnea, there are times where you're not breathing at night, and your heart kind of just suffocates, right? And you wake them up into rapid sleep. And that over time create a lot of stress in your system, including your heart, and that can cause atrial fibrillation. So these risk factors kind of shape the environment where your AFib lives in, and improving these risk factors can reduce AFib over time. So instead of AFib being unpredictable, we can kind of start turning AFib into data. We look for patterns, and once we see patterns, we can make better decisions. So with today's technology, there is many ways to monitor atrial fibrillation. So one of the cheapest one here is your blood pressure machine. A lot of these newer blood pressure machines can actually tell if you have irregular heart rhythm. And some of them can actually tell you if you have atrial fibrillation. A lot of you have these smartwatches. These smartwatches can alert when you have an atrial fibrillation episode, or if you suspect that when you have an atrial fibrillation episode, some of these smartwatches can actually let you do an EKG on. One advice I would have for these smartwatches is that try to learn how to do an EKG on these smartwatches when you're not in atrial fibrillation. Because the last thing you want to do is that you fluster with an atrial fibrillation episode and be learning how to do that at the same time. There are also a lot of outpatient EKG devices. They're very small. You can find them online. Right there on the bottom there, it's called a cardio mobile device. What that does is that it can help you do an EKG, and sometimes it can tell you if you have atrial fibrillation. Now, only caveat with these EKG machine is that you need to know when you're in an episode, and it needs to last long enough for you to take out the device, connect it to an app. So these are the ways that you can do it on your own to monitor atrial fibrillation. And then on the top right corner there, it's a picture of a cardiac monitor. So this is something that would be prescribed by the doctors, and this is probably one of the most accurate way, non-invasive way to monitor heart rhythm for days, even up to weeks. So even without any technology, your body tells you real-time information. One of the most simple tools that you have is your impulse. Your body tells you what's happening. So here's how. So essentially, you just place two fingers on your wrist on the palm side towards the thumb side of your wrist, and you count the beats. You bust out 5, you look at the 5, and you count how many beats you have in a minute. So typically, you want to stay anywhere from 50 to 100 at rest. And you want to pay attention to the rhythm. So in normal rhythm, it's kind of like a metric. It can be a little bit fast, it can be a little bit slow, it can be at normal speed, but it should come in at a regular time. Whereas when you're in atrial fibrillation, what I like to think about is a person kind of stumbling down the stairs. You walk down a few steps, and then you stumble down a few steps, and then you slow down again. So that's very representative of atrial fibrillation. So most AFib episodes are not dangerous, but there are situations where you should seek help right away. One of the big ones is chest pain. If you have an AFib episode, you feel like something is squeezing your chest, not letting go, something's sitting on your chest, you should seek help. That often accompanied with shortness of breath. So when it's emergent, this shortness of breath will feel like you're being drowned. You can't take a deep breath at all. So you should call 911. If you're losing consciousness, if you're passing out, you should call 911. And like we talked about before, if you have any of these stroke symptoms that we talked about, you should call 911. Or if your heart rate is just racing, won't stop. Say the heart rate, count your heart, your pulse, your heart rate is about 110, and it's been going on for hours. You should call. So everyone's AFib progression rate is a little bit different. And sometimes AFib can become constant. And when that happens, it's important to understand it's really not a failure. It's really a natural progression of AFib. So as you can see, when you first have AFib, it's only a small area in the heart on the left that's releasing these electrical signals. The more AFib you have, or the more area of the heart start releasing these electrical signals, and harder it is for it to get that on. So at the end of the day, what matters most is not just your heart rhythm. What matters most is your quality of life. It is about how you feel and having a safe heart rate. And most importantly, prevent complications like stroke. So no matter where you are in your journey with atrial fibrillation, there's always a next step. With the doctor and an individualized plan, you really should not feel like you're stuck. So while AFib can feel very unpredictable, if you can find the trigger, find the pattern, it does exist. If you can find the trigger, you have control over the atrial fibrillation, and we can always have a plan moving forward. And I'll leave you with this. Kind of look around this room, you're not alone. Even though there are a lot about atrial fibrillation that we still need to discover, there is a lot that we do understand about AFib. And that is something that we can manage. That is something that we can navigate together. Yes.
I have lots of questions online.
Okay.
Okay. So
Please repeat the question using the microphone.
You got it.
can thyroid conditions cause or affect AFib?
Yes, and normal thyroid condition, especially if you have a high thyroid level, that can trigger AFib.
Okay. Once you have an ablation, will we still need to be on a blood thinner?
The question is, if once somebody has an ablation, you still need to be on the blood thinners.
The answer for now is yes. So it's a little bit counterintuitive in terms of someone who has had an ablation. I mean, if they don't have AFib, why do I still need to be on blood thinner? So right now, our understanding of AFib is that AFib and stroke risk really depends on your baseline risk factor, which is that CHA2DS2-VASc score that we talked about. So even after an ablation, you would still need to be on blood thinner based on your risk factor.
Two more. Can a patient have an ablation with a vena cava filter?
The question is if a patient can have an ablation once he has already a vena cava filter.
So it depends on the condition of the filter. Most of the time we can still do the ablation.
And last one. My AFib first appeared immediately following a CABG in 2013. I've been treated and closely monitored for AFib since that time. Is it unusual to develop AFib following heart surgery?
This question will really point but yeah, the question is it is about a patient that had a cardiac operation, a coronary surgery in 2014 and developed atrial fibrillation and still struggled with that. And the question is if this is a common situation.
So I think I wouldn't say it's a common thing, but having cardiac surgery naturally create a lot of stress on the heart, and that increases the risk of triggering atrial fibrillation.
If I may just chip in, yes, atrial fibrillation after cardiac surgery is a very common situation. The range is anything between 30-40% sometimes of the patient. It is very intriguing because once again we loop around the same concept. Atrial fibrillation is a very complex disease. And it comes from different triggers and different things. Sometimes people may not have all the other risk factors which are known for atrial fibrillation, but in the context of cardiac surgery, then atrial fibrillation is triggered by other things, and namely is triggered by the fact that the heart has been manipulated, and that wherever the heart seats, which we call pericardium, there is some accumulation of fluid after the surgery, and this can irritate the heart and stimulate and initiate the atrial fibrillation. Now, sometimes we are able to revert this right away, and because this is a simple initial irritation, the heart can go back to its normal rhythm. Some other time, and especially if together with the coronary problems, there is also other problem with the heart, this initial irritation can continue being there, and treating atrial fibrillation afterwards can be more complicated. Please.
You said sleep apnea with stress on the heart. Well, I've got the CPAP, but I wake up probably 3 to 4 times a night. Is that considered putting stress on the heart?
If you wake, so the question is that, sleep apnea, you still sleep habit, you still waking up in the middle of the night to go to the bathroom, that's that with stress in heart. So if you have disruption in your sleep habit, that's with stress into it. Thank you.